forum. And for start, I think she has a few slides to get us on the nuts and bolts of the legal aspect of the resuscitation process. Can I invite Datin Ranuja? 1 minute, I forgot to take my glasses. She just needs to get a few of her belongings before she starts.
Hello, good evening, everyone. Sorry, I needed my glasses. I am not that young, as you all can see, and I still need to read something. So, do not resuscitate me. I intentionally put up, where's my slide? You all are not showing my slide? Okay. The slide was intentional. So I put up a lion, because aren't we all are responsible for our own life, but sad to say that that is not so. So I'm going to talk a little bit on the legality of omission that we are going to be talking about. What the law says: withhold or withdrawal of treatment without referring to acts including illegal omission. Section 32 of the Malaysian Penal Code says, in every part of this code, except where a contrary intention appears for the context, words which refer to acts done extend also to illegal omission. With that, the word illegal, as explained by section 43B, I don't have to read the whole section. I'll just take in a little bit part, just before we can start our forum, to tell you what is the legal situation in Malaysia. The word illegal or unlawful is applicable to everything which is an offense, or which is prohibited by law, or which furnishes grounds for a civil action. And in respect of the word illegal, a person is said to be legally bound to do whatever it is illegal in him to omit. A connection must be established between the omission and the harm, and may amount to any offense if the person is under a duty to act and fails to do it. So, a doctor undertakes to treat. A legal relationship exists between the two parties, duty of care, if you all remember, which gives rise to the duty to provide proper treatment. Proper medical treatment and care to the patient. So with this, I will start, we can start the forum. Just a little introduction to what the law is at the moment. Thank you.
Thank you very much, Datin. So in summary, actually, what you're telling us that we cannot do things that would harm our patient. Is that in the gist? Is that correct? Yeah, so when we omit to give medication, that will be also considered as a form of harm. Yeah. But before we start this forum, can I invite any of the panelists to help me clarify this matter? Because I also have a lot of problems in understanding. There is no definite definition of the word resuscitation as far as the Malaysian context is concerned. And different people, different disciplines, different medical personnel have different ideas. What does resuscitation mean? Some people may think resuscitation involves CPR. Some people may think resuscitation involves giving IV fluids, giving medication. So would anybody of the panelists try to?
Okay, thank you for that. Just to get the ball rolling, I think it is really, really important for starters to be clear, as you say, what resuscitation is. In the context of what we are discussing today, it is cardiopulmonary resuscitation, and that involves chest compressions, that involves assisting with ventilation, mouth-to-mouth ventilation, or artificial ventilation of some other means using a bag, or even intubation and ventilation. And this usually applies, CPR usually applies when people have a cardiac arrest. If you don't have a cardiac arrest, you don't need CPR. So that is CPR. You're absolutely correct. There are other forms of resuscitation as well. Fluid resuscitation for someone who is hypotensive. So these are all very different decisions, and they are kind of exclusive. If I make someone not for CPR, make a decision of that nature, that only means that I will not do CPR if they have a cardiac arrest. But they may still need intravenous fluids, they may still need intravenous antibiotics, it may still be appropriate to give them inotropes, it may still be appropriate to ventilate them if there is an indication. So I think it was really helpful just now to hear that proper medical treatment must be given, because just because someone is not for CPR does not mean we deny them treatments that are necessary. And I fear sometimes that the practice is that, oh, this patient is not for CPR, no need to do anything lah. But that's not right, that's not appropriate. And if I were to just tell a story, and I don't know how true it is, one of my former bosses once had a patient, not for CPR, and he was eating, and he choked on something, and he was like, couldn't breathe, and he collapsed. And everyone walked by and said, oh, not for CPR, no need to do anything. Oh, that's terrible, that's wrong. I mean, proper medical treatment is still indicated. You never foresaw that instance happening. It may be reasonable still to perform CPR or try to resuscitate this patient in that emergency. So I think just to get the ball rolling, it's really, really important to be clear what these decisions are about. A CPR decision is about CPR. If you make a decision not for CPR, it only refers to in the event they have a cardiac arrest. It should not influence their medical care otherwise. If they need an operation, and they are well enough to have that operation, they should still have it. But I accept there are risks. If there's something happens on the table and they have a cardiac arrest, then maybe you won't resuscitate that. It may not help a surgeon's outcome figures very well, but it's trying to deliver the best care we can and be transparent to the people we are looking after.
So do you think that the law is sufficient enough to cover this, or do we need to have a proper definition? Because like you said, different people understand differently.
Yes, Doctor, I would like to bring this attention to you. Of course, the law says it's a medical decision, and everything the doctor takes up, it's end of the day, it's the doctor's best interest for the patient, and he does accordingly. But then, as an individual person, suppose I don't want to be resuscitated, and you're going against my wishes. That is what I wished, and I have already informed my decision. But the law cannot do anything, because even if you had written a will, or living will, as some people come to understand, a will only speaks upon death. So till then, the will does not operate. So in this situation, Doctor,
Yeah.
can you tell me?
Can I interject, Ms. So I'd like to just add on a little bit about the resuscitation. So I think do not resuscitate is a very bad term to use, because it can be misconstrued, because that's why we now no longer use this term, and we actually say do not attempt cardiopulmonary resuscitation in the event of a cardiac arrest. So it's much clearer. I'm sure over time it'll become clear. The term will be refined. I know it's very long, so nowadays we have forms to fill in, because if you ask doctor to write about halfway, you cannot read the writing already. So then the thing to be very clear about is that only applies to that. So nobody should, in this day and age, use the term do not resuscitate, because it can be misconstrued. Do we not resuscitate by giving them a drink of water? I'm very thirsty, never mind, your DNA already can die because you're thirsty. Or if they drop their blood pressure, do we give them some fluids? If they develop infection, do we treat them antibiotics? If they don't have a cardiac arrest but they have trouble breathing, do we give them oxygen, or do we give them a little bit of support, respiratory support? So those sort of things are not being addressed when it becomes to the term DNR. So the term DNR actually should not be used. And Renuka brought up a really, really interesting point. And I think, to be honest, for doctors, we do not like to be the ones responsible for making decisions for patients. And why is it that patients think we make the decision? Because at the moment, people are not exercising their right to decide. They are not leaving advanced directives for these decisions. And life would be so much easier if people were actually given the information to make advanced, informed decision about what they want done in the eventually of each and every minutiae of a situation. Unfortunately, it is not always feasible. Yeah.
Okay, Prof. Tan, can I comment on that? You see, even if advance directive or power of attorney is given to a third party to decide on their medical treatment, a doctor can supersede all this and still make a decision. So that is the situation in Malaysian courts. They will not take up a case on this because a medical intervention is end of the day in the hands of the doctor. As I told you, it's a medical procedure. So a patient's wishes are not carried out.
I would like to say, just from my perspective as a palliative care doctor, I do feel that the patient's autonomy of choice comes for refusals in a way. If I refuse a treatment, then I have always personally have the stance that if someone refuses a treatment and I treat them against their wishes, I better be prepared to get taken to court for assault or battery. That's my personal stance, because we are doing something against a wish. And can I just ask all of you, if someone does something to you that you haven't agreed to, how would you feel about it? I mean, should we accept that? Is it reasonable? I mean, it's a complicated decision, and on one hand, I would like to respect my patients' choices if they don't want a treatment, and I will try my absolute best to do it. But I think these decisions are also sometimes a little contextual, in that if something happens and someone never foresaw that happening, then maybe it's important that the clinician has a judgment to make at the time. And as you very rightly say, even if you read things like the Malaysian Medical Council guidelines on consent to treatment, for example, a doctor can act in an emergency, and a doctor has to act in an emergency in the best interest of a patient. So if you're not sure, you may want to save the patient's life in the first instance because you don't know any better. And then you may have to deal with the fallout of that later. But in those circumstances, in emergency, if you don't know any better, didn't expect those circumstances, then I would never want to judge a doctor in that circumstance and say, you did wrong, because that person was just trying their best in that situation. Just to give you an example, I mean, a few years ago, I read an article, I think it was in the NAJM, and it posed the question, someone comes to emergency department, and he has a myocardial infarction, chest pain, and he says to the doctor there and then, doctor, if I have a cardiac arrest, don't resuscitate me. And then he has a cardiac arrest. And the question was posed to a number of clinicians, like a survey, to answer, what would you do? And did that person foresee that he would have a cardiac arrest there and then? And that's almost a best prognosis cardiac arrest in the context of a myocardial infarction, where someone could be salvaged. And the vast majority of doctors in the US, maybe it's very litigious there, but a vast majority of them said, I would resuscitate that person because I couldn't. Maybe he didn't know it was going to happen then maybe he wasn't adequately informed. So it goes back to your question, should we follow the person's decision? By and large, I will try my best to. The vast majority of people I see with advanced cancer, significant, incurable, life-limiting illness, if that is the cause of their illness and they're deteriorating as of their illness over time, and it reaches a point where they have a cardiac arrest, I will respect that decision, because I think it's important that people have honorable deaths and they get to go the way they want to go. That's my personal view about that. So I'll try my best to respect that choice.
Can I just add something? I feel that the nuances surrounding do not resuscitate in Malaysian context is very bad, because you see, like this forum, we are trusting onto a palliative and a geriatric. So we assume that people who have cancer or who have geriatric should be the ones dealing with death. actually it covers every discipline. So for the start, I think we should set up a committee to really analyze and come up with very clear definitions and as well as procedures with buy-in from the necessary parties who are involved in it, rather than leaving it to people like you all to handle this sensitive issue.
Fortunately, it's no longer left to us. I think every doctor who now graduates today knows that it's their responsibility. They don't refer to a palliative care physician anymore to make DNAR decisions. Yeah, that is thankfully a thing of the past now. But I just want to cover the whether you perform CPR or not. So there's also this principle of that withholding and withdrawing treatment. There should be no difference between withholding and withdrawing. Why? Because when someone says on passing, "Wow, if my heart stops, don't resuscitate me," and then drops dead, and then the heart stops and he drops down, you are not sure whether he was joking or whether he meant it. But if you don't do anything at that point, it's finite. Cannot take back already. So we know that death is finite. You cannot, there's no going back. So if in the event of any doubt, you should resuscitate. You should deliver the treatment. Why? Once they come back, if you change your mind, you stop. The person will still go bye-bye. Because people, no matter what we do, even if someone's heart stops, we bring them back. It's not like ER one, they don't get up and walk away one, It doesn't work like that. They usually need to be on a ventilator for a few days, at least, sometimes weeks, sometimes months. So there's still time to pull out later. Yeah, so that is actually the reality of things. Yeah. But things are also a little bit different. So sometimes the person suddenly stops breathing, and based on the information that you have that you think is adequate, you know that to resuscitate them is going to be we say futile, unlikely to be successful. So in which case, doctors have a duty of care. We are not obliged to provide treatment for which is unlikely to be effective. So so you cannot demand that I resuscitate someone if the act of resuscitation is very unlikely to be successful. And also, I would not deliver it because it's tantamount to assault. It's like it's like there's someone coming to me and say, "I want a blood transfusion." So why you want a blood transfusion? Because I don't like my blood. I need a bit more. Yeah. So you're like, but you're not anemic. You don't need a blood transfusion. You can't demand that I give you a blood transfusion. So it is exactly the same sort of principle.
Okay, doctor, can I put another scenario before you? If a person who is incapacitated and is terminally ill, would you keep him alive and let the suffering prolong or end his misery? What would you do? And of course, he is not in a position to give you consent because, incapacitated or they are in an unconscious state. What would a doctor do in that situation?
Okay, so the important thing in those circumstances is, as you say, acting in the law and doing what is right for the patient. I mean, within the law, we don't have the means to end someone's suffering. I mean, in Malaysia, at least, it's illegal to take any affirmative action to hasten someone's death or to do something like euthanasia. So that's not legal. We're not permitted to do that. I guess in those circumstances, I would probably try to look at a few factors. When we think about medicine, what does medicine aim to achieve? I mean, we try to cure people when we can. We like to relieve often and comfort always. There's that maxim that goes around. I think as far as possible also, we try to restore well-being as we are able and reduce suffering. So I would think it's really important to know, firstly, is that patient suffering and who is suffering? Is it the patient? Is it the family members? And why is it being viewed that way? If the patient is suffering, let's say from uncontrolled symptoms, physical symptoms, if they're unable to tell us, then we're sometimes having to make judgments. Is this person in pain? Are they distressed from other reasons? Can we help that through other means and relieve the suffering? So in a way, that's where palliative care comes from, relief of suffering and improving quality of life. In terms of making decisions on their behalf, again, there are no frameworks in Malaysia. If we try to follow good practices, maybe from other parts of the world where very clever people have thought long and hard about these things, then it may be an issue of trying to make best interest decisions for this person. What is in their best interests, and we would usually seek to elicit that from the family members who know them best. So if the family members can give us some idea of what was a meaningful life for this person, what did they worry about most? If they were in this situation, what may they have wanted? And that could give us maybe a sense of a grounding, what would be the priorities of care at this point of time. Because we may not be able to restore their function and this person back to the way they were before. Then it's a question of whether our priority is more about long-term survival and doing everything we can to keep them alive, or whether our priority is comfort, and then maybe the measures that we take are more comfort-oriented. So if they become more ill, if our priority is comfort, then maybe the measures we take are more comfort-oriented than life-prolonging. So we may not want to give them antibiotics, accepting that that may be the natural course of life that this person takes. I mean, death is, we don't like to talk about it, but it's a reality. From the day you're born, your end is coming. And whether we like to think it or not, it may be today, it may be next week, it may be in a few months' time or years. We have no idea. And it's something that, yeah, everyone kind of needs to be prepared for, in my opinion.
Sorry, can I?
Yeah, please.
Because from a legal point of view, I'm coming. The patient is already suffering. You want to keep them alive, right? Fine, I agree with you. But are you improving their quality of life? Would they, by you keeping them alive longer, are they going to have a better quality of life?
You know something? Law is actually the lowest level of ethics, isn't it? Because actually, the principles by which we are driven to make these decisions is very much not legal. We work by ethical principles. And the problem is that there is a misconception that to withdraw or withhold treatment is unethical. I think that's what you're getting at. So I suppose I don't have someone who's going to stab me next door, so I can say this. So yes, you're absolutely right. We got to weigh up the patient's, as a doctor, you know, I have to say we graduated from Nottingham University, so I don't know whether it's right or wrong, but the Hippocratic Oath was not something we took when we graduated. But I gather most Malaysian doctors, when they graduate, actually take the Hippocratic Oath. Is that right?
Yes, that's right.
Yes. So you first do no harm. And so the harm by which Datin Renuga is actually referring to is actually prolonging suffering. And yes, prolonging suffering is considered a form of harm, isn't it? So, one of the books that which every single medical student gets introduced to when they start medical school is Papworth's Primer of Medicine. Yeah, and it starts with, can anyone remember this? To comfort always, to relieve often, and to cure occasionally. And of course, as a geriatric medicine specialist, and then my husband, palliative care specialist, my poor children, every day at dinner time we rant. And we rant. What's happened to medicine nowadays? They've forgotten that actually we can't cure everything. And doctors do have that. Sometimes I call it the God complex. We think we have the ability to keep people alive forever. And yes, I totally agree with your reservations. And yes, we need to actually consider having public involvement in actually coming up with guidelines as to whether we actually resuscitate, when we come up with do not attempt cardiopulmonary resuscitation in the event of a cardiac arrest decisions. But the guidelines need to extend beyond that, because I think we're no longer referring to CPR, because in that situation, it's very easy to say, if the heart stops, let's not attempt CPR. But sometimes the heart don't stop one, it keeps going. Yes, so you have to do something else, you have to do something else like pull out the tubes to actually allow someone to go. So that goes beyond CPR, and the guidance would actually need to involve more than just CPR.
If there's anybody of the audience who have any burning question, feel free. Yeah, please, thank you. Please identify yourself and...
I'm Dr. Wong. I think most of you know who I am. I think there are a lot of terms that we have to clarify. And recently my wife spoke to me. She said she was listening to some Zoom and she said that we should draft advanced medical directive. So when she said that, I was a bit worried because there are many variations of before you are dying. Just like what Dr. Lam has said, a patient had a heart attack, if you shock him, resuscitate him, you can bring him back. And if you have a choke, and if you undo the choking episode, you also can bring him back. So sometimes this decision is not easy made by lawyers and also general public. So I'm a bit worried because if I put down that not for resusc, if I have a heart attack, then I said they're not going to resusc me. So I'm a bit concerned.
Sorry, can I interrupt you? Before you go on, I'm going to add on to what you say and maybe throw to the panelists. A lot of places in the West have got what they call tiered do not resuscitate context. In the event that I have a reversible condition, please continue resuscitation. In the event that I have irreversible brain damage, please do not do so. So there are many conditional advanced medical directives. So maybe we can hear from the legal point, or do you have any more questions?
Let me finish and
okay,
you can address that. So I think that's the proper way of doing it because the concern here is whether it's a medically futile to continue. And then the resuscitation initiative, it can come from the medical doctors or it can come from the family or the patient. And when you decide on this medical resuscitation, the usual communication that I had with my patient will be, we will still actively treat the patient, but in case he go into cardiac arrest, we do not resuscitate. And a lot of times more of communication. But there's another group of patients is that you are very sure that it's totally futile to actively treat the patient. Just like if you continue to ventilate and continue to give them fluid, it's not going to prolong his recovery. So we have to differentiate between the active treatment and not for resusc, and withdrawal treatment and not for resusc. And the reason why I say so, because when I was in Singapore, the family are very, very concerned. And we know that the patient is not going to survive. So we said, not for resusc, but active treatment. So we continue to ventilate the patient and we monitor the patient. So patient has no response at all. It's like GCS 15. But her life vital signs is sustained for about 1 week. Heart rate is about 30, 40, blood pressure is about 60. And by the time 1 week later, the family decide that we should not continue because you start to smell that the body is rotting, So sometimes we have to, the decision has to come from the medical rather than from the family insisting for us to continue to treat, even though not for resusc. And finally, a case that I had when I was working in UK. This patient is a Jehovah's Witness follower. So they are very sure that if you don't get transfusion, because the patient has a plastic anemia, the hemoglobin is very low, up to hemoglobin of 2. We said that if you don't get transfusion, you die. So they are very familiar and they are very sure of the outcome. If they are not being transfused, they will die. So this group of patients are well informed, they know the outcome. So we have to respect the patient's choice of not being transfused. So the patient autonomy and doctors' authoritative decision to help the patient must be balanced if the patient are aware. And I think that from this point of view, from the Jehovah's Witness, is the patient's autonomy and the right not to be treated. That's my comment. Yeah, thank you.
So I assume all those are comments rather than questions, you know.
Comments and questions.
And any of the panelists, do you want a response?
I can respond. Wong, I know about the Jehovah's Witness also because, you know, my degree is from UK also, law. Yes, in UK they respected that, but in Malaysia, no, it's not recognized. You know, a doctor's decision, if he thinks that he can save the life of the person, the decision is overridden. So in Malaysia, it's still it's a medical procedure and it's a doctor's decision that takes precedence. You cannot fight it in court of law. And to Prof. Tan, legal laws is not the minimum, it's the maximum. As long as you save life, you are free. The moment the patient dies, that's when, no action can be taken because, again, it comes with the best interest of the the patient, or the necessity. It comes back to that question, you know, whether it was necessary for the doctor to make the decision. This is a way the court avoids any kind of legal action against the doctors, because then it becomes a very defensive society. So that's what the courts are practicing now.
Yeah, what I meant is that we shouldn't be falling back on the law to make these kind of decisions. You know, we should actually follow the principles of medical ethics.
That's right.
Without falling on the wrong
We
side
should
of
not
the
allow
law.
the lawyers to dictate what doctors to do. That's right.
Sorry, could I just make a quick point first? I like to think that we should listen to our patients. And if our patients are saying something like they have an advance directive, as far as possible, like I said, we should listen to them. The MMC guidelines on consent does have instructions on advanced medical directives, and it does advise that if someone has a directive and it's relevant at the time, and the context is correct, we should try to respect it and adhere to it as well. So it's not to say that we don't have any guidelines per se. It's not a law, but I don't think you can get a law for this because it's not really a very clear-cut black and white scenario. There are many shades of gray, and the important thing is that listening and that negotiation and trying to understand one another. Rather than being too paternalistic in decision-making, it's trying to somewhat meet in the middle and share these decisions together as far as possible. That's what we should be trying to do. Sorry about that.
No, it's okay. Hello. I got some...
Sorry, can you identify yourself?
Yeah?
Can you please identify yourself?
Oh, my name is Bhaskar, and Dr. Bhaskar, I am the organizing chairman for this conference.
Yeah, for the benefit of the audience. Yeah.
Okay, I actually think this is a lovely congress, healthy aging conference. So we should be allowed to die healthy, dying also should be allowed. Because in this country, many of us don't understand. We are talking about, Prof. Dan is talking about ethics and all that, but I have the right to live or not to live. I cannot be asking my doctor, I mean, maybe I'm under the care for a short period of time, they look after me well, but you know, I know what are the difficulties that I'm going to face. One is financial difficulty, one is my family difficulty, one is the love birds, all are going to worry about me. So why should somebody come and decide whether this fellow should live or not live? Because I am giving my expression in the beginning itself. If something goes wrong, if I'm serious, please. You know, when I was the president of MMA and youth, when we went for WMA, there was a heated argument about euthanasia. So I was one of them who supported. I said, yeah, I mean, you must allow people to decide on their life. You can't, I'm not saying the doctors are wrong in deciding, or neither the government is wrong in deciding, but if I don't want to live on, if there are some people, crazy fellows who want to live, even in the dead bed, they want to come out and then walk around and all that. But I would rather go live peacefully so that everybody is happy. Family is happy, doctors also, I think they want the ICU bed more often than that, so we can go up quietly. So even instead of putting them under stress, and I think this government is outdated. They are not thinking about the good things that it can bring about. For example, the majority population in the country, for the Muslim, death is a better pathway. Even I think all our religions have said, if you die, nothing wrong, you go to a better place to live in. So I don't think anybody should interfere and tell me, hey, Dr. Bhaskaran, you are dead already, or already lying there for another 10 days. I'll keep you alive another 10 days. So this is my opinion. I think we should be allowed to make our own decision.
Thank you very much for your opinion. The very fact that there was a heated argument shows that there is a divided room related to this topic. So I don't think there is a clear-cut answer.
Yeah. These decisions are individual to an extent, but they have wider repercussions. So on one hand, sometimes we may be happy with the decisions, but our family members aren't happy with the decisions. And different people sometimes take different amounts of time to come to terms and acknowledge and accept. I mean, some families are really wealthy and they can pay for care indefinitely, and it's almost no skin off their nose, and they're perfectly happy doing it, and they feel it's the right thing for the loved one. I mean, for me, that's their choice. I wouldn't want to overrule the choice, but if the patient really doesn't want it, I will still try and argue on behalf of the patient. There are some people who are, very stressed and distressed because it's really expensive looking after someone long-term in a very infirm state. And maybe they kind of need to be given permission that is okay as well. They are not clear-cut decisions. I think if everyone were like you, wow, life will be much simpler in many ways. Thank you for that.
Yeah, Doctor, before he said, I wanted to tell you euthanasia is illegal in Malaysia. So there's no way, even if he wants to die.
I don't think any doctor on the Hippocratic Oath actually will take a life. Yeah, so actually it's quite difficult imposition on the doctor to actually do such an act. And I think there were issues with, because in the kind of the death penalty, isn't it? So there are actually companies which ban the use of their drugs to actually end life. So the US for some time couldn't actually administer lethal injections because in some states the mode of death is lethal injection. They couldn't find a drug to do it. Yeah, and then they tried a different drug and the person didn't die or something like that. So actually for doctors and even the pharmaceutical industry to actually have to do that it's actually a big problem. Yeah. So but then when it comes to these decisions, I know we want it to be personal, but actually keeping someone alive can be extremely expensive, and resources are finite. Yeah, the resources are finite. So, and there's no better example than what we're going through at the moment with COVID-19. Now, in July this year, the cases of COVID-19 went up. Last year, COVID-19 went up like crazy because Delta strain arrived. So I was on the COVID ward. It was my stint. So we take turns, and there were no ventilators available. So on my ward alone, there was about 10 COVID wards at the UMMC. My ward alone, there were 50 patients with severe COVID. There were 7 patients who had, we tried everything else, and they needed ventilators. There was 1 ventilator. So I remember sitting there. So at the moment, for a while, nobody got the ventilator because we couldn't decide who would get it. I was sitting there, just going, what do I do? Who do I give this ventilator to? Yeah. So and that is the sort of decision that doctors face on a daily basis. It doesn't need COVID-19 to actually, our ICUs are always full. So when we want to give these machines, when someone needs a machine, we decide who has that machine taken off them to be given to another person. That is the reality of, the current medical climate, because this sort of treatment is very expensive and resources are finite.
We have another audience. Can you identify yourself, please?
Yes, my name is Melissa. I just have a short comment and a question actually. The comment is that I found it humbling sometimes when I see a patient or work with a patient, and in my mind I'm thinking to myself, okay, this patient is suffering, surely the patient will choose not to be resuscitated. And in fact, the patient finds that, okay, I'd rather suffer than leave my spouse or my family. and they choose to be resuscitated, or quality of life. I think that they don't have the quality of life, but they're comfortable being, in a not vegetative state, but, paralyzed, and yet they choose to be resuscitated. And that I find is very humbling. But my question is, in Malaysia, I'm not hearing, as you guys talk about advance directive and decisions to not be resuscitated or to end life, do we address people who might not be in a mental capacity to make those decisions? What are the legal, repercussions and things like that? Yeah, especially when they're just together enough, they're cognitively together enough to say yes, but the wife might say, usually if he was all together, his old self would say no, he wouldn't want to. But now he's saying yes, he wants to be resuscitated, so.
Yes, I think to answer your question, I think Dr. Lam was clear on that they'll think of what the patient's want would be, what the patient's interest would be like. And if he's mentally challenged, still it is in the doctor's hands to see what is best for him. So, as I told you, in Malaysia, advance directives all doesn't work because doctor's decision supersedes all that. You see, what example I have to tell you is one of my clients, very recently, who is a mother. Her son committed suicide, but the suicide was unsuccessful. He was taken to hospital, put in a ventilator. He was there for 1.5 months. And the mother couldn't see him suffering. And he himself is begging, because now nobody could go, because of the COVID situation, begging to let him go. Let him go, please. And because he did try to commit suicide, it was unsuccessful. The mother was so painful, begging the doctors. Doctors didn't want to do that because he's only a boy of 40, not boy, a man of 40 years. And so she came to us as a lawyer, asking, can you intervene, do something? Tell the doctors, my son wants to go, I cannot see him suffer. Please let him go. The doctors refused. They didn't want to do anything. Then we had to call, because otherwise you have to get a court order, to make that decision, and no court will easily give. So I told, try to speak to the doctor. Apparently, even the senior doctors was willing to listen to the mother, but there's one doctor, a young doctor who was very enthusiastic, I think, still felt that he could be saved. So it was prolonging his suffering. Finally, they stepped in and withdrew treatment, and he had to go. So in a situation like that, that's why I'm telling you, it's still under the doctor's heads. No court will intervene.
I think that it's safe to say we don't have enough regulations, isn't it? Because we don't actually have this thing called a Mental Capacity Act. And because we're in a Healthy Aging Conference, there is an elder law that has been drafted. I don't know how many years it takes to draft a law, isn't it? It's taken 3 years, right? You're still drafting it, apparently. Have you seen it?
That the law is not for the patient, it's more for the nursing care homes,
Oh, no, that one is the PAFAS. That one is the private aged care facilities. But that one is passed already. It's just not being enforced. But there's a new law that's supposed to be coming out. That's the elder law. We keep changing governments, but we don't sort out our laws, Yeah, so as our population is aging exponentially, while they're busy changing governments, our laws are not being sorted. Yeah, so we need to do something about it.
No, we did speak, Healthy Aging Society, we did bring this up because we do cater for a lot of the elderly, and this is a big issue, like, euthanasia. Many of the educated group would rather had to have euthanasia. That's why some of them go overseas and have it done. Because Malaysia, it's illegal. When we went and approached, we were in fact spoke to some senior judges and all that, and also policy makers. It has to go through parliament. But you see what happens in our mixed society and our religious background of different sectors, this is not accepted spiritually and religiously also. A person like God wills, he takes it. Nobody should intervene. But then our question, the legal question is, medical intervention is also prolonging life. It's not natural. Don't you all agree? So why should if that person doesn't want to live, why do you want to intervene? But then they said in Malaysia, we have this filial piety. So a lot of parents will want to die to ease the children's burden. So that's why our society doesn't want to allow euthanasia.
There are a few comments from the website. Ismail Hamid actually asked the same question as Melissa asked about whether patients' right frame of mind to consent for DNR. And he added on an anecdote about Michael DeBakey. Those who know, Michael DeBakey was a father of cardiac surgery. And at the age of 95, he had a ruptured aortic aneurysm and he consented to be operated and he recovered. So when he was asked, why did you consent for surgery at the age of 95? His simple answer was he couldn't bear the pain. So sometimes when doctors play God, we really do not know what is going to be the outcome. Dr. Ben commented that he asked whether, he says that we should resuscitate if that's needed to save someone. We should not be worried to save someone in view of getting sued. So, and the last question is from Dr. Nick Aisha. She says that in many different countries, they practice the end of life wishes differently. Because by the time the patients become critically ill, they can't speak for themselves. And she's working at the primary health care, and she doesn't encounter this sort of cases very often. What is the role of the primary health care as far as this end of life care is concerned?
Wow, hard for me to answer from a primary healthcare perspective because I don't work in that sector. But in saying that, my counterparts in the community are community hospices. They are NGOs. They will go to people's homes and they will try to support end-of-life care in the home setting. So if someone has advanced illness and they are progressively worsening, some of the conversations that they may have before someone becomes too unwell, ideally, who would be the proxy decision maker in the event that you are no longer able to speak on your behalf? They may ask things like, in the event that things get worse, where would you like your care to be? Would you like to be cared for in the home setting or the community? I guess home setting or in hospital. The advantage of staying at home is you will be spared all the machinery and drips and blood tests and x-rays and whatever else, but you may have to resort to different means to try and control symptoms, palliate problems. You may have to resort to different means because you may not have access to all the things that hospitals offer. So I like to think that some of this can be done in hospital, because if you look back centuries, people used to die at home. They didn't die in hospital. But nowadays, more than 50% of people in Malaysia die in hospital because families they don't know what to do, sent to hospital. And in hospital, all sorts of things will be done to you. I mean, if someone wants to be resuscitated and it's appropriate, I agree entirely, we should do that. I don't want to deny anyone right treatment if it is appropriate. But it has to be suitable for the situation, because there are some people who are very clearly dying, and to resuscitate them, I would think is not very ethical, and we all have certain limits what we consider acceptable treatment. So I will do everything I can up to the point of resuscitation if someone is clearly dying. If there's uncertainty, then that calls for further discussions, what would be acceptable to the patient. Back to the question about people who can't make decisions for themselves. I guess something you're entitled to as well as a patient or a patient advocate family member is you're entitled to a second opinion. So if the doctor in the hospital doesn't agree with you, that can be requested, and maybe someone else may take a different perspective and may then be willing to take over the care of that patient in that situation. So if someone refuses to stop treatment because they are hopeful, and I understand why. I mean, the doctors are all trying to do their best. I think it's perfectly in your right to say, to get another opinion, and maybe someone else may agree with you and they may see things differently.
Well, what about the reverse situation? Maybe I should ask Dr. Tan. Let's say a patient who is in a futile situation, maybe terminal cancer or terminal COVID, keep me alive for a few days just in time for my relative from
that happens all the time.
I know. So what is your opinion on this?
If it's a few days and it's not too much effort, then I guess sometimes we would try.
At the expense
We
of
make
keeping
no
the ventilator for another
guarantee.
patient.
Oh, but if they are on ventilator, cannot talk already, that's different. But if it's about just, keeping the blood pressure propped up for a few hours, it's really difficult. But sometimes it's the relatives who ask for it. That is different because, the person is really suffering and they're asking you to actually deliver treatment that is futile. So I'm not obliged, but it is very difficult because sometimes relatives can be very intimidating also. Yeah, I do fear for my life often. I think I've shared that. I do feel that sometimes I'm going to get shot in a flyby shooting. Because, sometimes I actually sit there and say, I can't do it. And yes, they're entitled to second opinion. Take them somewhere else. If I find you another doctor, but don't make me do it. But they will insist. They said they don't want to go and find another doctor. They will want to make this doctor do it. Yeah. So it's a realistic situation in India, in China. People kill doctors because they fail to keep their relatives alive. And we don't talk about that, do we? Yeah. So we are not being protected either, and that's why doctors are scared, and doctors don't want to give up. So the reality is there's no law to protect the patient who wants their right to be actually protected. And this has been an issue we've known about for 10 years. I think we've been talking about it 10 years ago, right, Ranuka? And the law is still the same. The law is still the same. And there has been, in the University of Malaya, I was kind of involved in a project. It really was about elder abuse. So, because a lot of this is about elder abuse. And they came up with a lot of information about how elder abuse happened and things like that. And it was all to lobby for an elder law. And they succeeded in lobbying for the elder law. But then we go and change government pula. So somebody forgot to actually carry on this elder law thing. So they had already commissioned the drafting of the law. But we have no idea where it stands now.
Because Parliament is busy fighting other issues.
Yeah. Anybody else in the audience? Yeah, please, Dr. Wong.
I think the decision for not for research is not too difficult to make. The difficulty is on actively killing the patient, which is euthanasia, or passively killing the patient, which is withdrawing treatment. So this, in Malaysia, is sometimes we have to decide on withdrawing treatment, just like Prof. Tan was saying, when the resources are limited, which one that you're going to withdraw and who you are going to give. So I think it goes back to the 4 pillars of medical ethics that we have to consider every time when we are faced with this decision. First is beneficence, which is doing good for the patient. Are we doing good to the patient? Second is that we are not harming the patient. Third is autonomy. So in the case of Jehovah's Witness, it's their autonomy not to be treated, not to be transfused. No, you can force him and say, it's my right. I'm a doctor, I think you get transfusion, but what can you do to me? I don't want to get transfusion. And the last one is justice. So the justice is the resources that we have. Can we justify that we give these resources to a certain group of patients? And this can be improved if our Malaysian medical resources can be improved. And this is a comment for me. Thank you.
Thank you. Any other audience members who would like to share their experience? Yeah. Kindly identify yourself too.
Hi, Dr. Basil. I work with a lot of junior doctors, okay? So one of the things actually that people are not aware of is actually like all of these advanced directive. I work with a palliative physician. He sounds a lot like you actually, Dr. Lam. So,
if I may add on, Dr. Basil is the pengarah of Kuala Kubu Hospital.
Yeah. So he does give all these directives, okay, it's with the family members. But again, when family members bring their loved ones who are already under palliative care to the emergency department, the junior doctors will resuscitate. So maybe there should be more awareness, I don't know, maybe your opinion, more awareness on the public, on the family side, what to do, what is an acute illness, what is the natural death process for the patient, so that we don't waste resources and we don't stress out the person who's dying. So maybe you can hear your thoughts. Thank you.
Thank you for that comment. Very, very difficult problem, and I acknowledge it fully. The challenge for people in the emergency department is they don't know the patients oftentimes. They just come in. What do? I try to solve their problem. I try to keep them alive, because it's almost the default emergency department stance. And again, like I said, I wouldn't wrong anyone about this, but you cannot solve an upstream problem downstream, because if the team looking after this patient has known this patient for a while, has seen the cause of illness and what is happening, I think they can. Certain things, as you say, can be put in place such that maybe certain limits to treatment are imposed. For example, maybe do blood tests, maybe treat infections, but won't escalate to ICU or ventilation or CPR. I think certain things like that can be put in place if they are foreseen. But it's part of a whole system. You can't solve an emergency department problem just there alone, because this involves primary teams, this involves community care, many layers of service that need to collaborate and work together to solve these problems. So it's very difficult. I mean, recently I had a patient in UM also who kept coming back in with infections. And when I finally sat down with the family members and I said, what are you expecting? And they said, I just wanted to keep my mother at home, but I couldn't cope because she had seizures and I couldn't control that. And that's why I brought her to hospital. Doctor, I really didn't want to bring her to hospital, but I didn't know what to do. And so by the time this person pitched up in emergency, hypotensive, fever, started on antibiotics, started on IV fluids, started on inotropes. And I said, okay, if that's what you want, maybe we can try and think about how this could be done differently. I was lucky enough that there was a community hospice who could oversee the care or support the care of this patient. I tried to give them something to control seizures at home, to try and manage it chronically, but also if you had acute seizures, something like diazepams or buccal midazolam, some other ways to try and control it so that he would feel he had some means of something to do. Because as a family member, you see your family member having a fit in front of you, you feel so helpless. What are you supposed to do? And you bring them to hospital. So I think, in a way, the hospital doctors need to start listening to patients again. What exactly do they want? What do they need? It's not about, the patient dying already, what for you come here? I think the attitude has to be more, what can I do to help, or what is the issue now that you need support with? Because no one will go to hospital if they didn't need to, or if there was something they could cope with at home. No one likes hospital. I hate going to emergency because I have to go there, I have to wait, and whatever else. So it's part of the system, it's people working together, and that coordination of care is just something that we really struggle with, and hence they come to emergency, and the junior doctors, again, they're just trying their best. But you're absolutely right, more education, more patient respect, more honoring and valuing wishes, rather than just seeing people as illnesses and diseases and what am I going to do about it. It's a person in front of us. It's a person who has thoughts, feelings, emotions, family, and how can I look after you best and deliver the care that you need at that time.
Very appropriate last words. There's a person in front of us. It's not just anybody, it's a person. So with that, can we give the panelists a very big clap for such a wonderful session? I'm so sorry that we have run out of time, so we have to proceed. So thank you, everyone.